and it's time to open the second part of our session, which is introduction of PrEP challenging in community settings. We'll start with two presentations in a row. First, presented by Dr. Bartovská from Prague, Czech Republic. Zofia Bartovská is an assistant professor at the first medical faculty of Charles University in Prague, and also ID physician, and she worked in a military hospital as a HIV clinician. Second, because those two presentations will be put in one in a row, is given by Professor Justyna Kowalska from Medical University of Warsaw in Poland. Justyna Kowalska is an excellent medical specialist, infectious disease specialist, and HIV clinician and researcher as well, with large experience. She's worked in a hospital with a patient, but she also participated in many research projects focused on special population like women and marginalized population. So let's start with the first of our presentation at this part of a session. Zofia Bartovská, please, we're waiting for your presentation.
Good afternoon. I would like to thank organizers for my invitation and thank you for your attention in these difficult times. Here are my disclosures. I will share some of our experiences in PrEP introduction in Czech Republic. Here you can see our Czech guidelines that were elaborated based on WHO recommendation in 2017. And our center, HIV Center in Military Hospital Prague, is a pioneer in PrEP introduction in Czech Republic, and we have the most of patients, most of PrEP clients in Czech Republic. Here you can see our capital before COVID-19, and I will present you our data from the period before COVID-19, from October 2017 to January 2020. And during this period, we have 230 PrEP candidates. The number of candidates increased every year, and the majority of them were men having sex with men. And this is like in accordance with epidemiologic situation in Czech Republic. The average age was 35 years, and we recommend PrEP to all partners of newly diagnosed HIV positive patients and also to patients on post-exposure prophylaxis. Here you can see country of origin of our PrEP candidates. The majority of them were Czech, but we had 1/4 of foreigners, especially from Slovakia, which reflects unfavorable situation with prevention in Slovakia. We administered PrEP in 199 of total number of candidates, in majority of them on daily regimen, but we can also see a trend to on-demand regimen and switch of regimens according to patient's situation. We tested positively HIV in initial screening in 2 clients, and the rest of candidates they are postponed for PrEP. Concerning efficiency of PrEP, none of our clients was found newly infected with HIV during our follow-up. I will discuss a little bit side effects of PrEP in our cohort. We observed mild creatinine elevation in several patients. Usually it was sufficient to discontinue protein diet, to hydrate sufficiently. But in 3 cases, in 3 clients, we need to temporarily discontinue PrEP or switch to on-demand regimen. But all of these clients, they can continue their PrEP. They are tested more frequently. And we also, in our cohort, we have 2 patients with nephrologic history, and both of them are in high risk of STDs, so they are both on PrEP more than 1 year, and they don't have any side effects, any complications. We have in 19 clients, they discontinued PrEP for personal reasons. We discuss 4 cases of non-specific symptoms such as paresthesia, fatigue, headache, but in the end, all these patients, they continue their PrEP without symptoms, so no connection was found with PrEP in the end. In some cases, we consult clinical pharmacologists, especially in psychiatric patients with medication, and in some cases they recommend us both screening in cooperation with endocrinologists. Here I will discuss a little bit sexually transmitted diseases. We check all patients like initially and then during PrEP use. In the first 2 columns you can see the data from all candidates, and it is interesting that we had these two patients HIV positive in initial screening, and also we can see a combination of several sexually transmitted diseases. And in the 3rd column there are data of PrEP clients already. To conclude, STDs problematics in our PrEP cohort, more than 1/2 of candidates had a history of sexually transmitted diseases in the past, and about 20% of candidates were tested positively for some STD in initial screening, and during PrEP use, during PrEP follow-up, it was about 21.6% of new STDs. The most of these diseases were asymptomatic. This is in accordance with literature, and nowadays more frequent STD screening is recommended for patients on PrEP. Now I will discuss a little bit situation after COVID-19. In last 8 months, I will try to present you our situation in Czech Republic. In our HIV center, in our hospital, because of COVID epidemic, it was because we all have to work with take care of COVID positive patients, and we were able to take care also some acute patients, HIV patients, and so on. But it was not possible to take care of prevention PrEP clients. So we communicate via e-medicine, and we accepted only 53 new PrEP candidates. And nowadays we don't have any more capacity for new clients. And in the future it will be complicated to manage our clients, PrEP clients, in this epidemiologic situation. Fortunately, NGO Czech AIDS Help Society, which is NGO that is most active in the field of HIV prevention and social part of this problematics. They open a PrEP center, sexual health center, in March, and we collaborate with them. And they have already 108 PrEP clients, and some more of clients are postponed for PrEP, and if I can estimate PrEP use in Czech Republic, it's about a total of 500 clients. And we will see what this COVID epidemic will change in PrEP use in Czech Republic, if there will be a need of PrEP in the future in lockdown, and where it will be the best way to provide PrEP. And to conclude my presentation, there is a high demand for PrEP in Czech Republic. We found good efficiency, and PrEP was well tolerated by our clients. We suggest that PrEP implementation plays role in the decline in HIV incidence in Czech Republic over past 2 years. And we detected several new HIV cases and other STDs, mostly asymptomatic. It is favorable to increase PrEP availability to people that are in a high risk, and there are several barriers for this goal, but nowadays we will see how it will develop, especially with COVID situation. And I would like to thank special to my colleague Dr. Známal, and thank you all for attention.
Thank you very much for invitation and allowing me to present this case of successful introduction of PrEP in challenging communities, which I believe Poland could present one. So firstly, we know that PrEP has a significant influence of new diagnosis, but the evidence base shows on population level that this is mainly reflecting to gay and bisexual men. However, for women and who acquire HIV heterosexually and people who inject drugs, this is not being so spectacular. Also, at the same time, we know that hetero and sexual mode of HIV transmission and injecting drug use is the main mode of HIV transmission in Eastern countries and many Central European countries. We have performed some analysis of access to PrEP in this area, and we know that mainly the PrEP use is informal. There are no country-sponsored programs on a population level, so it is access that is being, injecting drug users are left behind. So that's my case referring to. Firstly, I would like to present Eva, and her partner is HIV positive. He has mixed drug abuse and he's not on antiretroviral treatment. She had unprotected sexual contacts with him. They are not using any conception, or they are not using condoms. And he also insists to have unprotected sex with her continuously. And as I specify, it is quite common for addicts to manipulate loved ones if it means they can get resources. And I think also sexual contacts could be manipulated in this way. So she feels a codependent person, and it's very difficult for her to take the lead in their relation. We also know from a published recently work that top 3 barriers perceived for prescribing PrEP are not enough knowledge, lack of experience, or that they are not covered by insurance. So in case of Eva, those were the three ones. And what about her partner, Adam? He's heterosexual man. He's using mixed substances. He's HIV and HCV positive. You can see some of his results here. He has been attending HIV clinic, but only occasionally. He was lost to follow-up. And that's also a case for him that he got HIV infection probably mainly through heterosexual contacts, because he was mainly dependent on non-injecting illicit substances. So injections were very occasional, and he was mostly using the exchanged equipment. So it is also a case for him that he did not have any PrEP access. And you can see from this work by Susan Sherman that only 1/4 of people who inject drugs had heard of PrEP in the study from US, from Maryland. But most of those who heard were interested in taking it. So we need to do better in approaching people also injecting drug users, because sometimes their HIV comes from heterosexual contacts. So what about Adam and Eva? Because we are interested in a couple more than just in individuals. Adam shows in 2015 for care after detox. He rethought all his life and he wants to start treatment. He's still addicted, but dose is mainly tramadol and alcohol. He's not having a very high viral load, which is also a good news for his sexual partner. However, he's still detectable. And he told me that his partner Eva, she is now 12 weeks pregnant. He still insists to have sex without condoms with her, and she agrees irrespective of being pregnant. So what did we do in this case? Firstly, we saw them as a couple. We put Konrad on OST program. He accepted it and was attending. He started regular meetings with psychologists. He started CART, of course, immediately, but since he was still detectable, he got undetectable within 1 month. However, he continued harmful drinking, which is very common for people who are on OST to continue some of their addiction. So what we did for both of them, the couple was consulted repeatedly, and I insisted to have them both in my cabinet so they would have the same information put in the same way. That's in my understanding and in my practice, this is extremely important, to consult a couple, not a single persons. Because Konrad was detectable and we didn't know how it go with his adherence, we put Anya on PrEP. She was pregnant. We know that PrEP is now considered safe and a possible option for pregnant women who are partners of HIV positive men with uncertain adherence. So we did that. We involved also the environment of the couple. So we invited Konrad's mother, and she was very open to help, to care for him and for a family. It helped a lot. And in result, Anya delivered a healthy boy. So that is when we could say it was a successful PrEP story. But I'm very far from saying so, and that's why my presentation has this successful in brackets, because we know that drug dependence is far more going beyond just having a healthy partner or a healthy baby. It is how to repair a relationship broken by addiction. Addiction is a family disease, and I wanted to present it with a strong picture made by police from, I believe, LAPD, showing a pigeon nest that was organized in left syringes by an addict group. So it's definitely not the best example for nesting, but people would have, of course, families, even if both of them are addicted. And we need to consider this as a wider case. It's not only PrEP, it's also involving those they depend on, which means families, for example. And it is ongoing and important and neglected part, because if you look into the studies we've done in ECE network group, people who inject drugs, women, pregnant women, and sex workers, they are they are a vulnerable population and hard to reach population across the whole HIV continuum. So also testing, it's very difficult to test them. And if we don't test them, they don't know, they are not aware that they have infection and can transmit it. And then just a couple of words on where do we go, because I think that we are now transferring into a fantastic time for PrEP when we would have, in addition to oral PrEP and different oral PrEP strategies, we would have cabotegravir coming maybe to the field and some other investigated agents. And we've heard during this year's virtual IAS that cabotegravir is really getting a good result, but it's only MSM and transgender that was not introduced, the idea to injecting drug users and other populations. And the other populations I want to mention is non-MSM, so it's heterosexual couples and especially women who are presenting worse adherence. They have different pharmacokinetics, and we need more studies in this area to also offer people at need who are heterosexual, offer them adequate PrEP. So as I mentioned, it's also it's all about other population that needs to be developed, and I really like the way IAS USA summarized that by saying that identification of individuals for whom PrEP is indicated requires individualized approach. And I would like to highlight that individualization because it requires understanding of people needs, and it requires that people understand what is needed for PrEP to be effective. And with that, I would like to thank you very much and wish you good results in taking care of couples and taking care of families, not only seeing them as individuals at need for PrEP.
Thank you, Dr. Bartowska. Thank you, Professor Kowalska. Now it's time to move to the final presentation by Professor Jeffrey Lazarus. Professor Lazarus works as an associate research professor at the Barcelona Institute for Global Health Hospital Clinic, University of Barcelona, Spain. He's also active in research, and he's the main author of a paper, famous paper published in 2016, defining the 490. So his presentation is called Update on the Development of the HIV 490 consensus statement. So Professor Lazarus, please.
Thank you, Chair, and thank you for this opportunity to present an update on the HIV 490 consensus statement. Just a little bit of background. We're all now extremely familiar with the UNAIDS WHO 90-90-90 targets. They've guided the policy and research agendas for HIV care delivery for years now and helped catalyze a coordinated global action response. They've spurred significant progress on linkage to care, access to antiretroviral therapy, and viral suppression, though more work is needed to address gaps in the cascade of care, as you see here on the bottom right. We're well aware that people living with HIV are aging, and that's good news. But it also means they're at higher risk of multi-morbidity. We've discussed this, and here you see some of the figures for how much more multimorbidity, how many more comorbidities people living with HIV are likely to have. And we also know that discrimination continues to be a persistent problem for people living with HIV. With all of that in mind, and thinking about the 390s from UNAIDS, we proposed the idea in 2016 of a fourth 90. A fourth 90, which would mean that all people living with HIV have good health-related quality of life. Now, we proposed that 4 years ago, but how do we measure it? And what exactly is meant by a fourth 90? Well, in the HIV field, there is strong interest in introducing a fourth 90 target relating to the long-term care of people living with HIV, but no consensus has emerged regarding how to operationalize the fourth 90 in terms of policy, practice, and monitoring. In order to strategically support health systems in improving long-term care outcomes, HIV stakeholders need a clearer shared understanding of what the fourth 90 represents and how progress toward the fourth 90 should be measured. So with this consensus statement that we're developing, we expect to publish it in July 2021 for the AIDS 2021 conference, in which we define the HIV fourth 90 and constituent measurable elements. Global and national health system monitoring should be modified to better reflect progress on HIV fourth 90 targets and sub-targets. Global, regional, national, and subnational stakeholders should be guided by this consensus statement in pursuing strategic goals that will optimize long-term care outcomes for people living with HIV, including non-clinical outcomes. The fourth 90 consensus statement is being led by a steering committee of 11 experts that you see here from around the world. They represent a range of disciplines, as well as the people living with HIV community itself. And as we've held our first meetings, we've been thinking about the framework for defining and measuring the HIV fourth 90. As a starting point, we took our article from 2016, in which we identified two domains, the domain of comorbidities and the domain of self-related, health-related quality of life. We realized that self-reported HRQOL encompasses other key fourth 90 issues. And last year, throughout 2019, we had discussions in which we started to expand from 2 domains to 3 domains, changing comorbidities to multimorbidity, retaining self-related reported HRQOL, and adding in the important domain of HIV-related discrimination. We're in the midst of ongoing discussions about how to incorporate other important issues like frailty, disability, the concept of healthy aging, and other paradigms that are currently emerging. So what we plan to do from November and into the coming months into 2021, as we prepare for finalization and the Delphi method to get agreement on the consensus statements and ultimately publish them, is to review a series of scoping reviews that bring together the evidence and that will advise the panel experts on how to best understand selected domains with the latest available evidence. We will undertake that Delphi process I mentioned, in which we have a series of at least 3 meetings, now of course all virtual, in which we will review the consensus statements, vote on them, discuss, revise as we seek to reach some form of consensus. And finally, as mentioned, we expect and hope to publish this consensus statement in July 2021 for the AIDS 2021 conference, where we'll have a special session to discuss the consensus statement. We'll be working during this time to align with the UNAIDS strategy development process that's going on and that we recently participated in, a focus group discussion discussing healthy aging and the fourth 90. And we'll be working with WHO, the ECDC, other key stakeholders to make sure that this consensus statement is fit for purpose to guide us into the next era of HIV outcomes beyond viral suppression and what it means to have a fourth 90, to define it, to measure it, and to incorporate it into other paradigms and other approaches to ensure that everyone living with HIV has a long and healthy life. Thank you.
Thank you very much, Professor Lazarus, for your presentation. This was the very last presentation of this session, and I have to open the discussion right now. My first question is posed to you all, because you're coming from different regions, different countries. Spain is a country where the PrEP service, PrEP medication is covered by health insurance. It's reimbursed. Poland, Czech Republic, belonging to those countries where the reimbursement process has not been finalized yet. Do you think that the reimbursement of a PrEP medication is absolutely essential for a good PrEP clinical practice, or that it's possible even without the reimbursement to manage well or effectively the PrEP care? Justina, would you like to start?
Oh, thank you, David. I think you've acknowledged very important issue here, that is the difference between the way the healthcare is delivered. I don't particularly think that the cost of PrEP medication per se is a problem in Poland or Czech Republic, because we have quite good access to generics. The problem is to have access to insurance covered doctor's visit and STI testing, HIV testing. So this is the real true issue for us, because as we know, PrEP care is to a large extent increase in the number of tests you need to do and the quality of tests you perform. And this is the real cost that, in my understanding, should not be covered by individual, but by a healthcare service. I would refer the question of covering the cost of medication to the same issue in the field of contraception. So if in the country the contraception is covered by insurance, it should go for PrEP as well. If not, then I think that is reflecting the quite leveraged and equivalent care costs.
Thank you. Professor Lazarus, would you like to comment on that?
Yep, I was just going to turn off my extra lamp here.
We can see you very well, Jeff.
I have an automatic lamp that's shut on right now. Yeah, I guess my concern is that where it's not coveraged, it's going to be accessed primarily, well, by those with the resources to pay for it. So we're going to start to create, differentials. It's an additional cost for people to protect their health and to protect the health of others. And that's why I think it needs to be covered. What you said, Justina, makes good sense, and I think it's discriminatory to not cover PrEP. I understand the perspective of payers, and they need to assess, a new cost and figure out what it's going to cost per year, but we also need to calculate the cost savings. So I do think it's going to be a major problem to really, roll it out as you described, David, in settings, particularly, among populations that are disadvantaged, unless it's free of charge.
Thank you. Zofia, would you like to add something?
Thank you. As already Dr. Kowalska mentioned, I think the price is not a problem. In Czech Republic, when we started with PrEP 3 years ago, it was about 6,000 crowns, so it was quite expensive. But nowadays, it's about 20-30 euro per package, so that's a good price. But in Czech Republic, this is the patients, they pay this price themselves, but the costs for tests and our visit, examination by doctor and STI screening is covered by insurance in Czech Republic for a while. So I think that's quite a good way, but we will see how it will be in the future. But it works like this, that it's a kind of prevention of like whole population. So
okay. Thank you for your input. We've received one question from the audience, from Mr. Hazak from Czech Republic. He asked if we see any role of clinicians in removing those barriers in PrEP and advocating for better access in PrEP, particularly in countries with no national PrEP program, like for example, Czech Republic. So, Zofia, would you like to comment on that? Because it's from Czech Republic or anybody else? So what is the role of the clinicians, you know, in removing the barriers and obstacles in installing of PrEP?
I think nowadays epidemic of COVID-19 is really barrier, especially in our clinics. We have to deal with COVID, and we don't have like enough of time and possibilities how to deal with PrEP nowadays. But I think the role of clinicians, like in maybe as we do it in Czech Republic, we work also in Lighthouse, in this AIDS society, help society NGO, where is PrEP center. So maybe this is the way how to deal with it. And nowadays also we make a lot of e-communication via phone and email. So maybe this will be the possibility of.
I see the clinicians as those who are in a closer contact with the patient, so they got a possibility to get their opinions. They can communicate with them, you know, in contrast with those, you know, who are central authorities. And I think that the clinicians could, you know, bring the opinions of the patients to the other pieces of chain, you know, like central authorities, healthcare providers, etc. That's my view.
Okay, right.
Professor Lazarus?
Thank you. I mean, I agree with you, Sophia. Clinicians are extremely, or can be extremely powerful advocates, and particularly national, European, and global clinical associations. I guess the authorities will expect the patients to want PrEP. And we know from the history of the AIDS movement that if they don't listen, well, people can take to the streets. But I'm not sure the movement for PrEP is strong enough, particularly now during COVID-19, to really affect that change. And I think clinicians will play a pivotal role in helping the authorities understand why it's so important to have this additional form of prevention.
So if I can add something, being this clinician we talk about, I've been a fully devoted HIV clinician, and also with a focus on prevention in any possible way. But since half a year, I share my time with COVID. So today I'm after a quite hard time in a clinic, and I see it as a vulnerability towards the PrEP strategy, because the bottleneck is access to clinicians, to medical care. And I wonder if we want to have a wide PrEP utilization, to what extent could we make it a shared care? So I think that we could involve more nurses, healthcare advisors, others than clinicians, maybe to promote and use anonymous HIV testing clinics. It all depends, again, I refer to what you started with, David, that each country has a slightly different setting of how they see a public health care. But anyways, I see myself being also non-judgmental, enthusiastic, and also destigmatizing, etc., I see myself as a limitation because there is such poor access to clinicians nowadays, and it showed our very well that this is this weak spot, the Achilles heel. And maybe we should think more like Africa is looking at it. So to have it more as a program that is easily accessed through pharmacies, and of course there is follow-up and advice and counseling, but it shouldn't be limited to having a prescription, etc., and a doctor's visit, and especially having a follow-up each 3 months. I think that's too often. We are now, we can't be spared for prevention programs in terms of clinicians.
Thank you. Coming back for a while to the 490, Professor Lazarus, you know, since 2016, since you have published your paper, did you adjust or change somehow your view, you know, did you get some feedback from your colleagues on or other clinicians that has you know, changed somehow your view, you know, that is now different from the 2016?
Thanks, David. Yeah, we got a lot of feedback. So first, we heard from the community that it's really not about good health-related quality of life just for those virally suppressed. It's for everyone living with HIV. So, you know, since the 390s keep getting smaller and smaller, we added in a fourth. That was the thinking. We changed that. So now you saw the image really encompasses all the 390s. Also, we expanded our understanding of what do we mean by health-related quality of life. That's been discussed during the workshop. But on the one hand, it's the comorbidities, often the perspective of clinicians. On the other hand, it's the self-perceived quality of life, the perspective of people living with HIV. But it's also the structural issues, the structural discrimination that you can't get a job or a mortgage because you're living with HIV. So sort of a legal perspective as well, which foments this stigma. So what we're doing now is trying to put all of that together into a definition and a metric of the fourth 90 that encompasses both concrete health issues like comorbidities, multimorbidity, including polypharmacy, the trying to decide which tools make most sense to measure self-perceived health-related quality of life, and finally, how we can address those legal structural issues, the barriers, you know, for employment, mortgage, etc.
Thank you. Yeah, anybody wants to pose a question? You know, anybody from the you know, the speakers?
I think I would like to ask about your experience with PrEP in other groups than MSM. And I don't really mean women, for example. It's more like injecting drug use and other groups like sex workers. In Poland, just to start, it's almost not existing for these people. It's just casual, and it's very difficult to access them because they are really individual and different life stories.
So in Czech Republic, I think the situation is similar, or let's say the majority of our clients are MSM. We have only 2 women in total, and these women, they are like sex workers, but some porno industry and so on. Concerning IV drug users, we don't have any programs. And also, for example, this is that's but I don't know how to implement it. And in this case, maybe it could be a problem of price as well, and adherence and so on. But I think in Czech Republic, maybe it's a little bit different situation comparing to rest of Eastern Europe. In Poland, in Ukraine, maybe this you deal more with this problem. And I have one more question for you, Dr. Kowalska. What about like government approach in Poland, like to PrEP, especially in MSM, as last days there is so problematic this prohibition of abortion and so on. So I can't imagine how it works with PrEP in MSM, because in Czech Republic, even which is quite liberal country, we have in the beginning quite problems to accept this prevention.
So as you can see, we have quite a character. So if there is any legislation that we don't agree, there is demonstration, there is almost a revolution. There is no such revolution in terms of HIV and PrEP. I mean, it means that it's never been, it's never been under any specific law that would, you know, somehow target that. But the problem is that the agendas that are to be the ones to stimulate this progress in PrEP, especially in prevention, in a wide way of prevention. PrEP is just a tiny bit of it, we all know. So on the contrary to Spain, in Poland, the governmental agencies are not really seeking for solution and being proactive in proposing that. In this perspective, it's always the clinicians to raise a hand and say, what about these people? And it shouldn't be like this. Me as a clinician, I'm not a politician. I don't really feel like a fish in the water in these relations. I should just be and serve with my advisorship, and that's all. To tell if this is really cost effectiveness or not, or how to implement that. But the problem is not the governmental agencies not being proactive in this area, and also in legislation. And this legislation goes far beyond things. So in some areas, it is really being debatable what legal acts have been decided to be voted and accepted, like with the abortion. And on the other hand, there are many legal acts that should be decided and they are postponed or disregarded. And I guess it's probably more or less the same in politics across Europe with different shades.
Thank you. We're close to the end. We're running out of the time a little bit. So thank you very much once again to all the speakers for your presentation, for participation in a debate, in a discussion. I would like also to thank to the people from the audience who posed their questions. Thank you.